Okay, welcome back. If you don't mind advancing the slides so that we can just see each other, since we don't need the slide right now. Okay, so in we go to about an hour's at least scheduled time to go back and rethink again about the evidence, not just on the comparative clinical effectiveness, but yes, we're going to talk further about some of those ethical aspects and benefits that could even extend beyond the pure health benefits and take votes on those. So as part of that, I think we do want to go ahead and introduce the first voting question to tee up the further discussion. So if you can put that up, please. All right, so it's important obviously to think about the patient population. So we are going to have 3 different votes on clinical effectiveness that are focused on the evidence in each of these 3 patient subpopulations within the clinical trials. So the patient population that we should be thinking of, I'll just read it, are those children with pre-symptomatic late infantile MLD. Okay, that's the first of the 3 votes that we'll take. And the question is the currently available evidence adequate to demonstrate that the net health benefit of Arsa-cel is superior to that provided by usual care? And the options are yes or no. So let's ask Grace, please, to again reflect back on the description of the evidence that you presented earlier, hit the highlights, and the rationale behind the ICER evidence rating, if you can do that. And do please refer to the tables that are in the evidence summary from the report that the CTAF panel has. Grace?
Yes. Thank you, Steve. So this is for the pre-symptomatic late infantile population. As you remember, these are the youngest children on disease onset from age 6 months to 30 months, and they have a rapidly progressive form. In your evidence packet, figure 2 is the survival curve for the pre-symptomatic late infantile population. And that's the one where you see a fairly large difference where all of the pre-symptomatic late infantile treated children survived, and many of the natural history children in the natural history cohort did not. If you look at then table 4, which is the ARSA activity levels, those were quite high and remained high in the pre-symptomatic late infantile group. And similarly, tables 5 and 6 summarize the progression on the motor progression for this group from GFM-FM88 scores, and you can see that those are relatively preserved as well in this group. And finally, in terms of harms, in this group, all the children will have suffered some harm from the busulfan conditioning, including febrile neutropenia, stomatitis. But in terms of later harms, the post-gene therapy harms are mainly that there could be some MLD progression, although this happened less in the late infantile cohort. So the anti-Arsa-cel antibodies, which I think our clinical experts said mostly resolved. So in terms of our evidence rating for this population, we gave the Arsa-cel an A rating based on the fact that these children appear to have, the treated children appear to have relatively preserved motor and cognitive function and survival compared to the natural history cohort.
Thank you. Say-Lee, you remember that you had a question. I'm glad you're back. All right, let's get a chance to address it.
I'm not sure this is the, so I guess I am mostly worried about the current plan for expanding screening and what the concerns and how that may identify what the rates of false positives are. So I'm mostly concerned about when we talk about a pre-symptomatic population, it's basically children who are not clinically abnormal in any way, but we are going to have to identify them as being very likely to become symptomatic in the future. And so I feel like the evidence base feels very strong for siblings, where the genetics are such very likely that we have a high degree of confidence of what that the patients will become symptomatic. But I worry that when we broaden this to a population level screening program, that we may end up identifying a broader spectrum of disease that we may not have the same level of certainty that a patient is actually truly pre-symptomatic. So when answering this question, am I supposed to assume that everybody that we identify as pre-symptomatic are definitely going to become pre-symptomatic, or do I have to kind of take into that uncertainty into the answering this question as well?
I'll have a short answer to that, but then we definitely can talk about the current status of the tests, the evidence on the test. So as you can tell, we did not try to evaluate the sensitivity or specificity of the screening tests. We did not factor that into the modeling either, of whether there are false positives or false negatives. You're right that the prior probability of screening siblings is a very different situation than generalized population screening. On the other hand, my guess is that the genetic aspect of this makes it relatively easy not to have false positives or false negatives. But let me hand it over to either clinical experts or Turin. I know you've been very involved in this. Please tell us what you can about the state of the diagnostics in terms of its performance.
It's Taryn.
Sorry about that again.
No worries. Yeah, the false positive rate for the screen is extremely low. In fact, we've had in the pilots, we've had no false positives. And the screen actually, there's 3 parts to the screen. The sulfatides are measured first, and then there is a biochemical and a genetic analysis. And the mutations there are in the late infantile form, there are known late infantile mutations. And so we know that if a child has the two late infantile variants, that it will develop late infantile MLD. So I think.
So how do you, so just again, apologies because I haven't looked at this at all. Is there an initial screening test that then is confirmed by genetic analysis? Okay, so you have a gold standard that will always be there as part of the process. It's not like you're going to take an initial screen and then treat on that basis.
Correct. The screen has 2 parts to it. It has they test for the sulfatides first. You have to have the sulfatides, and then do the biochemical with the URSA level and urine, and also the mutation analysis.
So in a sense, there can't be a false positive from your way of thinking. Am I right? How could there be a false positive with
there can't be, because
and I'm not sure how you would know if it's false positive, because people are probably going to treat that before seeing what happens.
Well, the reason the test is testing for sulfatides first is because there is in the population 1 in 12 people carry the pseudodeficiency, and most newborn screenings are done on enzyme levels. But we couldn't do that on MLD because of the false positive. We would have gotten a lot of false positives because of the pseudodeficiency. Okay. And that's why it's got the 2 parts, with sulfatides being first.
Great, thanks, Dave.
I was going to ask that we have Dr. Fumagalli actually jump in a bit on this, because I do think when we get to population level screening, we're going to potentially encounter some mutations that we just don't know what they are. And so I know that there's been experience in Europe with the screening that has looked good so far, but I'm not sure that I'd go so far as to be sure that it will be perfect.
I confirm what Darren was saying, that the first level is the sulfatides levels, because in general, human that accumulates sulfatides in blood and urine will develop the disease. Is also the confirmatory test it is used to confirm the diagnosis, sulfatides. We use that first to detect the patient with high level of sulfatides. ARS activity will confirm that there is a defect in the activity of this enzyme and exclude patients who suffer from defect of saposin B, so the activators. And this is a second level to exclude subjects that cannot be treated because suffering from other genetic disorders. And genetics allow to detect we know a lot of variants in the ARSA gene, and we have large database with mutation, with also correlation with phenotype. So in the majority of cases, we are able at least to predict the variant of disease, distinguishing between severe allele and mild allele. I confirm that there could be cases of variant of uncertain significance, having high level of sulfatides and low level of ARS enzyme. This subject would almost certainly develop the disease. What could be a little bit more difficult in some cases, a small proportion of cases, to establish in advance the disease variant. There are additional methods under study on that regarding a new test for ARS activity, able to distinguish between early and late juvenile. And we are working as an expert team to evaluate each single case identified in newborn screening in Europe to establish together if the child should be treated or not, like it is happening for Krabbe in US. So a medical expert team that evaluate each case. And the patient or subject with the uncertain variant, the idea is to follow them over time to decide when and if to treat.
I wonder if we would be as coordinated here in the States as that process sounds in Italy as you're doing it. But that's very helpful. Maria, please go ahead.
I just want to quote Dr. Laura Dang, who's not here today, who is a leading neurologist in the U.S. who studies MLD and works on this issue and is working with the Europeans on a collaborative effort to streamline identification and get the treatment to the children who need it. Obviously, the clinicians are very focused on making sure they get this treatment to the appropriate patient. And she has said to me, I understand that for the FDA and regulatory agencies, it is a huge lift to approve a very expensive, innovative therapy for an asymptomatic infant. But MLD is so devastating, it is worth taking that risk. So I just wanted to quote Dr. Edang and her perspective on their tireless work to solve this problem and address the VUSs that will inevitably appear. They will be doing a protocol of following children up and monitoring ARSA levels. But more importantly, I think the clinical teams believe that this disease is so devastating that taking the risk of missing your window to treat them, it is worth reinventing the medical paradigm of treating children who are not sick. So thank you.
Say, come on back. Looks like you've got a comment or question.
Yeah, I mean, I think the thing that I'm just wrestling with is, I guess, as a non-pediatrician, I know nothing or very close to nothing about this disease. I'm just trying to leverage kind of my experience with other diseases and kind of things that we teach medical students about how even incredibly accurate diseases, when the prevalence of the disease is so low, the positive predictive value end up looking not so great. And so that is, as the question as currently defined, pre-symptomatic, that presupposes that I know with 100% certainty that this person will become symptomatic without treatment. And the question, so that's kind of where I am struggling with. And certainly it sounds like all of what I have heard so far suggests that we are kind of using several different tests, using different aspects of the disease process, knowing things about the natural history. This does feel like as close to the ideal situation as possible, but I do think the hard lift is just that for a rare disease, I don't know too many things in medicine that are 100%. I don't know many things that are 99%, and this may be 99.99%, but even at that rate, what I am worried about is that this is not a non-toxic or non-dangerous therapy. If we are identifying somebody as a child as pre-symptomatic, we are going to expose them potentially to a very severe intervention. And what is so that's kind of where I'm struggling. But I think if I was the term pre-symptomatic, this child will become symptomatic, I think the data is overwhelming that this is beneficial.
All right, let's see. Paul, go ahead. Oops, Paul was there.
Yeah,
Oh,
there we go.
you're on mute there.
Yeah, so it seems there's kind of two questions that are being discussed. One is whether we can accurately make a diagnosis, and then the other is whether we can accurately predict the phenotype. And I think, as Taryn and Jessica and others have stated, I think the risk that we're going to incorrectly diagnose someone if we're looking at accumulation of substrate, which is sulfatides, enzyme activity, and molecular changes within the ARSA gene is exceedingly low. It's, I can't say it's 100%, but it's got to be very, very low. The phenotype question may be a little bit stickier. And I think, we may have to, I think the vast majority of kids, we're going to be able to have data based on what the genotypes look like to be able to help us in predicting that, but that's not going to be probably universal either. But as we get more information, we'll be able to better identify the mutations and be able to predict based on the combinations that exist what the phenotype is going to look like.
Great. David?
Thanks. And obviously, Steve, you and the panel may decide to handle this differently, but as we were thinking about both this review and this voting question, we were not trying to answer the question that you're asking, say, which is we were trying to answer the question in people who are going to develop this, most of whom at this point in the US are going to be identified as siblings. What do we believe about this therapy's efficacy? We didn't count the cost of screening. We think that an entire analysis of screening is a reasonable thing for FDA to do, for ICER to do potentially if there are costs involved, but that wasn't the question we were trying to answer. We were trying to answer, look, there are people who are pre-symptomatic, who everyone knows is pre-symptomatic. What do we think about this therapy for them?
I'm going to let more comments come, and then we may have to move forward with the vote pretty soon. Rita?
Thanks. And I guess I'm having a hard time reconciling pre-symptomatic with diagnosis, because to me, pre-symptomatic means you don't have symptoms, and diagnosis is for people that have symptoms. And those seem to be getting confused here. And that is concerning, because as Say pointed out, even with a really high likelihood ratio, and we don't know what it is, with a rare disease, which this is, you're going to have a lot of inaccurate false positives, and it will not perform well. And so and when I asked the question earlier about the screening, my impression was the idea was to be screening all babies, not just siblings. And I think that makes a big difference, because if we're talking about all babies, then that is a concern for pre-symptomatic.
I think we can absolutely raise as an issue, and noted in the report, that the role of screening will be considered in a sense on its own merits to a certain extent. But as I've heard it, it's not so much that the diagnosis is right or wrong. It is the phenotype question. because if you have, this malfunction in your ARSA cell, you will have some variant, but how bad it will be may not be as clear as it has been from the screening of siblings. Although, again, they have shown pretty good predictive ability, they think, within that set of siblings. So the idea that there would be false positives seems essentially off the table as far as a diagnosis, because we diagnose high cholesterol without symptoms. We do a blood test.
Let's not go there. Okay, but can we, it is my understanding that the pre-symptomatic data we have was on siblings. Is that correct? But now this question is not just about siblings.
So it's mostly siblings, but there are cases that were identified, that before clinical symptoms were observed. So there's few.
And how were they identified, Grace?
So, if they were, I think, well, we're sort of basically parsing out symptoms is like there are people, there have been children identified, and the clinical experts can help answer this as well, but children identified, for example, who had gallbladder pathology, who didn't have any motor or cognitive decline. And so those children, are diagnosed because of some a disease that manifests itself without the motor and cognitive symptoms. And when we look at pre-symptomatic, it's not that they haven't manifested any symptoms, like clinical symptoms of motor and cognitive decline, but they have the underlying pathology is still there, right?
Right.
Right now, without the universal newborn screening, it's exceedingly rare, but it does happen.
Right. And I could see that, but I can't see right now universal screening. I'm thinking, for example, about the genetic testing that's done now for mothers, perhaps of advanced maternal age or whatever, and the recent data that has shown the false positives and the devastation that causes, with including women who are now aborting. I mean, this was prenatal screening, but aborting based on what was thought to be very accurate testing. I mean, it's a very fraught area to do universal screening. If pre-symptomatic means you had gallbladder pathology or siblings, to me, that's a different question.
All right. I'm going to say now already that we are not going to vote on the merits of broad population screening. That is not the purpose. You can, for the extent of this vote, do what David did, which is to assume, and Grace, assume that pre-symptomatic means that we know that this person will develop the condition, but hasn't yet, and they're in this first category that we're looking at. So we will return. We can talk more about the population screening kind of message we want to send later about the potential for further research, but it's not an area in which I think we have the expertise in our own report, or, I'm sure that Francesca could tell us a lot more about it, and Maria, if we wanted to focus on that. But I think we should focus for now on the body of evidence as we have it among those who have been identified as having the genetic diagnosis, if you will, of this condition without having suffered any symptoms yet. Bob?
I just want to point out, I hope we really highlight this and you'd drill down into this thing in your final report, because we're dancing on the head of a pin of whether this is a genetic based thing or whether whether we're in utero or post utero kind of thing. Genetic testing heads that direction, and we all know that. Mm-hmm. If both the parents are carriers, parents are going to end up getting tested beforehand. We're into a minefield here where we really had to come up with some clarity of something, I certainly hope.
Okay. Francesca, why don't we have you get the last word on this, and then we'll take a vote.
Just with the experience of 20 years of seeing patients, I would say that if I see a child with no ARS activity, no protein, it will for sure accumulate sulfatide, for sure have a demyelination in his brain and neurodegeneration. Not having no protein means developing for sure the disease. Is 100%, I would say, as a medical doctor following this patient. We can argue about later onset variant, but in pre-symptomatic late infantile, in few months after birth, you will develop symptoms. You will never achieve independent walking. You will never speak. You will never, so I don't know how to say, but all the children with these genotypes and zero activity will develop symptom in few months. So we have no time even to think about I will develop or not. I had a family that was offered to enter in the clinical trial and refused because the parents were not convinced the child will develop the disease, but unfortunately he developed exactly the same way of the older sibling. I have many families with two children with the same identical disorder, even knowing to have the disease before symptoms.
Okay, Jeff, I'm going to ask you, I'm sorry to hold your question. Maybe we'll have time to come back to it later, or your comment, but let's go ahead and put up the voting question again. All right, so again, the patient population are those children with pre-symptomatic late infantile MLD. Is the current evidence adequate to demonstrate the net health benefit of Arsa-cel being superior to that provided by usual care? Please go ahead and vote. We have 13 voting members of the CTAF panel. Okay, let's show the results. Okay, 13 yes and 0 no. Thank you. Let's move forward to the next subpopulation. So now we're talking about children with pre-symptomatic early juvenile MLD. Same question, is that evidence that we currently have adequate to demonstrate the net health benefit of Arsa-cel superior to usual care? Grace, you want to again headline the findings?
Yes, thank you, Steve. So in your evidence summary, if you look at figure 3, that is the survival curve for the pre-symptomatic early juvenile population. And this is the one where there was one death in the in this pre-symptomatic early juvenile group, treated group, Arsa-cel group, and the natural history, because the disease progression in this group is a little bit slower than in the late infantile group. You're just starting to see that the progression of disease and deaths in this population, whereas in the treated group, aside from the one death, all other children were alive at the last follow-up. Similarly to the pre-symptomatic late infantile group, the levels of ARSA activity were all normal or supernormal, and the motor assessments of motor function, the GMFM and the GFMC, were also relatively well preserved in this population, as well as cognitive function. So we also gave this population an evidence rating of A.
Okay. Any questions? We may have covered some of the most important territory with the discussion of the first subpopulation. Any questions about this one? Okay, let's go ahead and put up the voting question. All right, yes or no, the evidence for this subpopulation adequate to show superior net health benefit? Waiting for one more finger to hit the button. All right, if someone's having a difficulty using the voting software, can you please let one of the ICER staff know through the chat function? Otherwise, let's go ahead and show the results. Oh, there we go. Please show the results. All right, 13 yes and 0 no. All right, into the third. Children now with early symptomatic, early juvenile MLD. Okay, Grace?
For this, I'll refer you to figure 4 in your evidence summary. That's the survival curve for the early symptomatic, early juvenile population. In the analytic, this is the portion of the population where in the analytic cohort, there were no deaths. However, there were 2 deaths early in the trial that were removed post hoc because these 2 children who were removed would not have met the current treatment criteria. They had too many symptoms to meet the current treatment criteria. So those are in the early symptomatic, early juvenile group. If you look at table 5, 6, and 7, which is tracks the motor function, you'll see that the benefits in the early symptomatic, early juvenile group is somewhat less than in the pre-symptomatic group. They still gain benefit compared to natural history, but not the difference is not as great. And then there is a concern that we heard from clinical experts that there's a possibility of the busulfan conditioning hastening progression of disease in people with early symptomatic, early juvenile disease, and therefore they might stabilize in a worse state than previously than they were pre-treatment. So for these reasons, we had less certainty about the benefits for gene therapy, for RSSL, for this population, and we gave this population a B+ rating.
Right. Which still, in our lexicon, still means that it's better than usual care, but we have less certainty about how much better. A little or a lot, somewhere in that range. Francesca, feel free if you'd like to comment on this patient subpopulation. It was the one that got a little bit less, if you will, of a vote of endorsement. Not that it's a lack of endorsement, but if you will, there was more uncertainty, partly because of the magnitude of the benefit seen. And again, as Grace said, partly because of the protocol, the removal of 2 patients from the protocol. Please go ahead.
Thank you for asking. In fact, I just want to clarify that the inclusion criteria for early juvenile were modified over time. We were larger at the beginning and allowed the treatment of patients with an IQ above 70. Now the criteria has been restricted to above 85. And moreover, the inclusion criteria regarding the motor capabilities was a little bit, larger before, because the patient are able to make 10 steps independently where it could be included, while now we know that this is too late. We have to treat patients still able to walk independently for long distances. Why we learned a lot during the clinical development, because we learned that the juvenile phase, so in the symptomatic phase, there is a phase of stagnation followed by this rapid phase of progression, and we have, as a medical doctor, really to identify when the patient is closer to this phase of rapid progression. And probably when the IQ go below 85 and when the child is losing the capability to walk independently is too late. This is the reason why, as of today, we would not include this kind of patient. These 2 patients were really, really close or at the time of rapid disease progression. So what we observed after treatment was exactly what happened in natural history of the disease, so a rapid progression. Then probably the death of these 2 subjects was also due to the fact that both families decided not to use the GE tube. So probably their survival seemed even shorter compared to the natural course of the disease, because in the natural history of the disease, the majority of the families choose to go for feeding tube, while these 2 families decide not. So we even shorten the phase of the last phase of the disease. I want to point just one point, the other aspect of the disease we could prevent, so the onset of epilepsy, severe spasticity and pain, and dysphagia. All the surviving patients have good swallowing capabilities, are able to communicate and to interact with families and peers. This is not possible the same age in untreated patient.
Got it. Bob, I see your hand. I just want to invite Dr. Orchard. Do you have any different opinion that we should hear about this issue?
No, I think that what's been said is I would certainly concur with. I mean, some of these patients may have been totally asymptomatic until they're 4, 5, 6 years old, and then they have this rapid period of decline. And if we can't intervene before that time, one's going to expect that they're going to rapidly progress, and they may make it through the procedure, but their level of functioning afterwards is going to be poor. So being able to identify these patients and intervene as early as we can is key. And again, newborn screening is probably going to be the best methodology of picking up these patients before they're devastated. And I think it's probably important for everybody to understand, and probably maybe everyone does, but we generally don't see any recovery of any function in these things. So what we're trying to do with the intervention is to stop any additional progression that might be occurring. And so, anything that's already been an issue for the patient, it's not going to recover after transplant or gene therapy, even assuming your enzyme levels are very high.
Okay, thank you. Bob, Say, and Rita, I want to go relatively quickly so we have good time to talk about the potential other benefits, et cetera. But please ask your question or make your comment. Bob?
Let me try to put 2.5 or 3 together here quickly. Francesca just spoke to, and I appreciated what she spelled out with this. Isn't this the area, isn't this the population where we're going to start to see, because newborn screening doesn't get us anywhere for 5+ years to in a general population sense. Isn't this the area of this disease where we're going to see more people coming out of the woodwork, more kids that haven't been diagnosed before because of various issues with the system? And we've been speaking to it from the medical side about, early diagnosis. When can we see it? When can we identify it? At what stage can we catch it, kind of thing. I'd particularly like to ask the patient experts, probably the hardest question that I've ever asked anybody before. From your perspective, having seen the disease from the other side, from the real world side, when is it too late?
Maria or Aaron?
Yeah, I think it's very difficult to address that question. I mean, I saw a newly diagnosed symptomatic late infantile patient on Monday, and we just sent her home to die, essentially. So the juvenile patients, there's some variation in terms of how they present. The last patient we performed gene therapy on actually had an isolated cranial nerve finding that led to her being initially diagnosed. So she doesn't have any ongoing motor problems, but I would still consider in that early symptomatic, early juvenile population. The other patient that we did had significant motor issues and that patient did not do as well. And so, trying to identify these patients and characterize them in terms of what the rate of progression is going to be and what they might look like after intervention is extremely difficult.
Maria or Taryn, if you wanted to also answer, because I know Bob directed this partly to you, but feel free if you'd like to pass.
No, I'd like to answer.
Please.
Knowing that if there are any changes occurring in the brain before we see symptoms is the point where we need to treat. And I know in a late juvenile trial that's being done by Orchard, because of an older sibling, this little 2-year-old was diagnosed as pre-symptomatic, but it's because in her MRI, they were looking and they knew what to look for. They saw the changes that were happening already, even though she didn't have symptoms. Her sister presented at the age of 10. She's 2. That little girl was treated and is doing as a pre-symptomatic late juvenile and is doing as well as your pre-symptomatic late infantiles and early juveniles. So I would say any child diagnosed through newborn screening needs to be treated. And we won't know that until we actually start off-label or whatever treating these kids and getting data. But once symptoms appear, it's too late.
I'm gonna second what Taryn said. So the disease progresses, and I'm going to correct my language of pre-symptomatic. It's subclinical symptoms that are not being picked up in terms of motor function. That's what I mean. So once the disease has shown itself in terms of motor function or cognitive function, it's too late. So this is a disease that can only slam the brakes on disease progression using gene therapy. You cannot restore the myelin, as many people have said. I think the grander question in terms of when is it too late is a really impossible question to answer. I have had families who have been, only wanting the best outcome. I've encountered families who said, unless my child is as close to neurotypical as we can get, I don't want anything else. Other families would say to me today, give my GMFC 6 child gene therapy because I would rather have my child alive even without function. The clinical teams, the medical community, you all are making a decision on value and what this therapy is worth. I personally agree that it must be done early. I hope that we have as broad an off-label use as possible, but I will never be able to speak to the desires and wishes of my families because I think everyone has a different question in terms of what and how long we can wait, when we can intervene. But clearly, when you think about the holistic healthcare system, and I'm someone who teaches on health policy, I agree that the best outcomes that protect the system from expensive medical care have to be considered in this kind of form. For the families, it's a different calculus. But for what you're thinking about, of course, outcomes that improve quality of life, do not strain the economic resources of an already overstrained system, have to be part of the calculus.
And I would
answer the question.
I would also add that we know, since my kids were diagnosed in the 1990s, that this disease is a continuum, and it could start. We really don't know when it starts, but it is a continuum, and it will start. It probably starts way earlier than we think it does.
Okay. I'm going to ask, there are three of you with questions. We need to make this extraordinarily quick. If you have a question that you think is going to raise a philosophical issue, let's try and come back to it in the policy roundtable. So if we can do 3 questions in 3 minutes, I want to make sure we have enough time for the other questions. Say.
Grace, I just wanted to ask, it sounds like the folks the kids who were excluded was in part because of the changing definition of, was the same exclusion process applied to the natural history arm? That would give me a little more confidence that we're doing a apples to apples comparison.
I will actually defer to Dr. Fumagalli to whether the natural history arm also had the same change in inclusion-exclusion criteria.
In fact, the natural history capture the natural history of the disease. So all the patients followed in the trial since the first symptoms to the long-term follow-up. The analyses are done for age-matched patients. So taking the treated group, comparing the patient that at the same age are in the natural history group.
All right. I don't think that probably answered Say's question. So
it's not so easy. It's not so easy analysis because also in the pre-symptomatic group, you have all the patients in the natural history. All the patients in the natural history have been included when symptomatic. But you look to the patient compared to the same age, at the same chronological age, to be the Kaplan-Meier curve.
Okay. I will try to obey my own dictum to go quickly, but I'll pass that on now to Rita.
Thanks. My question is for Grace to clarify figure 4. I just want to be sure I understand it because the x-axis is chronologic age. That's what it says because there's very few in those groups. In any
Yes.
of the groups, and I'm just thinking the 2 out of those, the 2 that were excluded post hoc is a big number for the treatment arm. What is the time period of treatment if this is the chronologic age on X?
Right. So yes, thank you, Rita, for that question. So it is chronological age, and then each dot in the figure represents the last known follow-up of the patient. So that can range anywhere from the patients who were treated more recently. I believe, if I remember correctly, it's something like 2 years of follow-up to 12 years of follow-up is the longest follow-up that we have.
Thank you, Grace.
Thanks. Jeff, I'm going to allow you to have a question.
All right, this is about, you piqued my interest when you mentioned the MRI because when I've seen patients with this, we all start the workup when they're symptomatic. You see the MRI and you're like, oh my gosh, and that's when you go down the metachromatic leukodystrophy path. I've never obviously seen anybody with pre-symptomatic. Do they inevitably have MRI changes? Because if they do, that's going to, make it a lot easier to say this patient is getting disease as opposed to this is somebody with a ticking time bomb, but we don't know.
Thanks, Jeff. That's a good question. I didn't focus on the MRI changes in my report, but my understanding is that, there's a phase where children develop normally. They had the gene defect, but they were developed normally, but then they start to have MRI changes, and then eventually they have clinical changes. And so when you look at the MRI data, all the children have MRI changes. Did the treated children have less MRI changes than the untreated children? Dr. Orchard or Dr. Fumagalli, did you?
Sorry, I'm going to need to move us on. I'm sorry. So let's go ahead and take a vote on this question. And again, this is just a different patient subpopulation, the same question for early symptomatic, early juvenile MLD. Is the evidence adequate to demonstrate superiority of Arcicel to usual care? Everybody check. There we go. Almost there. I will start to talk again in hopes that one person is figuring out how to enter their vote. But if not, we need to keep moving on. Could we please see the results? Okay, 11 yes and 1 no. Okay, if someone is having trouble with the voting software, please let one of the staff know so that we can make sure that we try to get 13 votes each time. Okay, it ended up 12-1. All right, that's great. Thank you. Let's move on now. And we're going to talk about contextual considerations and potential other benefits. The CTAF panel is familiar with these questions. I'll try to be brief so everybody understands what we're about with these questions. So again, we are talking about the patient population here. It's basically looking at 2 of the populations, the pre-symptomatic ones, if you will, pre-symptomatic late infantile or pre-symptomatic early juvenile. We just thought it would be easier to frame this rather than trying to mix in everything at once. Now, when anyone is making a judgment of the overall long-term value for money of a treatment like Arcicel, first set of questions is what's the relative priority that should be given to actually any effective new treatment for MLD on the basis of the following 2 contextual considerations. The first, shown on the next slide, is the acuity of need for treatment of individual patients based on their short-term risk of death or progression to permanent disability. Now, partly because I'm keeping my eye on the clock and partly because I have a great appreciation for the level of understanding that has been brought to us through the report, through the kind of guidance from patient experts and clinical experts. I don't think we need further testimony on what it's like for a child and certainly a family with MLD. So based on the acuity of need for the treatment of individual patients on their short-term risk of death or progression to permanent disability, please rate the relative priority from very low or to very high on the basis of this contextual consideration around the severity of the illness. Please go ahead and vote. Great, let's see the results, please. Okay, 12 very high and 1 high. All right, let's go to the next question. Again, the CTAF panel is aware that these questions exist to try to capture the potential for there to be other benefits in different types of conditions. We're not trying to make some specific distinction here for MLD, but the other kind of facet of severity can be the magnitude of the lifetime impact on individual patients of the condition being treated. For a very, very rapidly progressive and fatal condition, that can be obviously implied to have a high magnitude of lifetime impact, even though it's not stretched out over decades. So please go ahead and vote on this one. Waiting for that 13th person. There we go. Thank you. Results 13-0. All right. Now we're going to shift gears because we're still talking about the same patient population, but now want the CTAF panel to think about ICER as a treatment and that relative benefit versus usual care that you've just voted on. And we want to talk about what some people would call spillover effects, or things that we haven't fully captured already in talking about the health effects of these treatments. So what are the relative effects of ICER versus usual care on the following outcomes that also help inform our judgments about value for money? Next. First, patients' ability to achieve their major life goals related to education, work, or family life. Again, we've talked about, obviously, the clinical benefits of treatment. This is meant to talk about, in a sense, how that stretches out and affects the arc of people's lives sometimes. We want to talk about whether ICER would have either a major negative effect on patients' abilities to do what they want to achieve in life versus a major positive effect. We heard wonderful comments and experiences from the public commenters and from both the patient experts who've been with us all day. But I want to offer them again another opportunity, if you'd like. When you see this question, what does it make you want to say about the impact of ICER on children's ability to achieve their major life goals? Taryn or Maria, anything?
In our observation of families, it's made a major impact, major positive effect. These kids are going on to live normal lives versus what their siblings can't do.
Okay. Great. Maria, if you want to add anything, please do. Otherwise, we can go ahead and vote. Okay, let's go ahead and vote on this then. All right, we have 13 votes, 13 major positive effect. Great. Next question, ICER versus usual care on the impact on caregivers' quality of life and or their ability to achieve their life goals related to their education, work, or family life. Again, it's been front and center in many ways of what we've been thinking about today overall, but Maria or Taryn, again, anything you'd like to share about how this affects families, the caregivers?
This is a tremendously devastating disease. I will give the example of my husband had multiple myeloma, and he relapsed while my daughter was in the hospital, and he probably delayed his treatment for about a month. Not relapsed, the disease had come back. I mean, this disease is so catastrophic. It shortens the lives of caregivers. It is devastating. I cannot underscore it enough. And this therapy insulates families from that. There's a line from one of our parents in their nice testimony who said, this treatment doesn't just save a child, it saves a family.
Thank you. Karen, anything else you want to add?
Yeah, and I can speak from our own family. Our life is totally revolves around caring for our older daughter. And I've seen this make a major change with families that have been able to continue their lives, unlike what we've been able to do.
Thank you very much. Okay, CTAF panel, please go ahead and vote. The impact of Arsa-cel on caregivers. Thank you. Let's see the results. Major positive 13. All right. Next. Okay. Some treatments are for conditions where we have a special historical or other view of health inequity and the ability of a treatment to make a difference there. This is generally intended to capture racial and ethnic inequities as we've experienced them in the healthcare system. So I will just point out that there's no strong racial or ethnic difference in the prevalence of this condition as far as the team was aware. And so if anybody has a question or a comment about this, otherwise we can vote.
It actually does have a very high incidence in the native indigenous.
Oh, that's true. That's true. That's true.
And in Eskimos.
Yeah. So the incidence in indigenous populations may be as high as 1 in 2,500.
Okay. Any questions or commentary on this question before we vote?
And it is also high in closed ethnic groups, like the Pakistan and India.
Okay. Francesca, please.
I just want to add that being a recessive disorder where in the community where consanguineous marriage are common, the frequency is higher, also having more than one kids affected by the disease. Yes.
Got it. Okay, thank you. CTAF panel, why don't you go ahead and vote, please? All right, we can see the results. No difference 7, minor positive effect 6. All right. Next voting question is, and this is something we actually only ask of a rare condition when there's a first-time treatment for it of this nature. So the question is, and we actually learned this from patient groups when we were reviewing spinal muscular atrophy, and we learned about the impact of having a new treatment on the entire infrastructure of care, which means, the effects on how people think about screening, on the awareness of clinicians about the condition, the fact that parents don't have to be the only repository of knowledge and infrastructure for care information, and as the dissemination of that understanding about the condition, so that in a way having a first-time treatment for a serious condition can really revolutionize the entire way that we kind of view care and how it's handled. So I'd love to hear any testimony on that feature of this treatment, and maybe we could hear of how it's affecting European health system, since it's been approved there for a couple of years. But Don, go ahead if you wanted to also ask or say something.
That was going to be actually my question. I wanted to make sure I knew how long this treatment's been available in Europe and what we know about this question as a result of the experience there.
Francesca, I have a feeling you're a good person to ask about that.
Very difficult question. In fact, is almost so the treatment was approved by EU at the end of 2020. We were also at the end of the pandemic or in the middle of the pandemic. In any case, it's 2 years that is available, and not all the countries have go through the process of price reimbursement negotiation yet. Major changes, pilot studies ongoing newborn screening. No, not yet countries with that enlarge the national health newborn screening panel. So we are not seeing yet the effect of newborn screening of the entire population. Still need of education of healthcare professional to speed up the diagnosis, in particular in my countries. There are still some very delayed diagnoses. What I can add, what is working well across European countries is how to speed up the process of access to treatment. So when a patient is identified, there are ways to send the patient to the qualified treatment center very, very soon, because there are few qualified treatment centers across Europe, currently 3 centers. So some patients have to travel from one European country to another one, but we have some government that already approved the cross-border treatment. So we are happy about that process ongoing. Another step.
Let me just add in, because that's very helpful. We were running a tiny bit over, so I also wanted to invite Maria or Taryn. I know it's not approved yet, but feel free to share your perspective on how it will change the infrastructure. Maybe it already has catalyzed some actions or changes, so please let us know.
I cannot underscore how it's going to transform the healthcare system in terms of putting in the minds of clinicians the idea of treating and diagnosing patients before when they have subclinical symptomology. It's going to put, I see it as, a remarkable challenge in terms of opening up a possibility where we'll do more than cure people, we'll actually prevent them from ever becoming sick. And I'm very excited that MLD will be one of the first disease states to push that new thinking of personalized medicine to a really remarkable and transformative level.
Great. I'm going to move us forward. We can talk about this further on the policy roundtable also, for sure. So let's go ahead and invite the CTAF panel to vote. This is our last voting question before the break, and then we will come back for the policy roundtable. So from major negative to major positive effect on how ICER may revolutionize how patients are cared for in ways that extend beyond the health effect. Okay. We have a sticky, there it is. Sticky number 13, it always seems. Major positive effect 7, no difference 4, and minor positive effect 2. All right, this is going to be very helpful when we write the final review and incorporate the richness of this whole section and all of the discussion and testimony that came earlier that has fed into it. So again, I want to thank you all for this. I want to give everybody the allotted break, but let's come back at, actually, I think we should go ahead and give people a full 10 minutes. So let's come back at 5 minutes after the hour. 1:05 Pacific, 4:05 Eastern, and we will get right into the policy roundtable where we will have some, I think, really interesting broader policy themes to pick up on. So we'll see you in about 10 minutes.